Hi everyone. We might just wait a couple more minutes. I know there are a few people still about to zoom in, so we'll just give them a couple of minutes. Okay. Looks like everyone's still joining, so that's okay. We'll move ahead. Firstly, hi. My name's Tracy Pickler. I'm a proud Bundjalung Gullible woman from Casino, Northern New South Wales. It's lovely to have you all join us today for the Aboriginal Health Team's Reconciliation Week event. Firstly and most importantly, I'd like to call on Aunty Marcel Townsend Cross to come and do our Welcome for Country to today's event. Thanks, Alice.
Thanks, Trace. So I'm Marcel, as many of you know. I'm Jagulna. That's a bit of language that I've picked up here in Bundjalung country, and that simply means that I'm not a Bundjalung person, but I'm from elsewhere. My heritage is Birrapai Wattamai country, and I have a really strong Irish heritage, which kind of explains a lot. But anyway, yeah, so kind of the brunt of all jokes, right? And today I'm offering an acknowledgement of country as a non-Bundjalung person. And I really want to recognise where we are here in Widjabul Waible country in the heart of the Bundjalung Nation, and really recognise Widjabul Waible peoples, the wider Bundjalung peoples and Aboriginal and Torres Strait Islander peoples across the country, and their practice of caring for country. And that care for country translates as care and nurturing for all people and all who live on country. You know, our feathered friends, our four-legged friends, our hopping friends, leaping friends. And yeah, we're all here and we're all okay because Aboriginal and Torres Strait Islander people care for country. Okay, thanks.
Thanks, Mars. So today's all about Reconciliation Week, and today's event is about recognising this year's theme, which is now more than ever. I sat for a long time trying to work out a couple of words about what this means to me, and anyone that knows me knows that a couple of words just wasn't going to cut it. So then I thought what I would do is flip this around and let you think about what reconciliation means to you and what will your first start be in change for reconciliation. Today, you will hear from a diverse range of well-respected researchers in their fields. They're highly experienced, high experts, and are deeply passionate about what they do. They immerse themselves in their communities and the communities that they work within. They are powerful, strong people and who are dedicated to the health and empowerment of Aboriginal and Torres Strait Islander people. In saying that, I'd like to call upon our first speaker, Emma Walk, who's a proud Bundjalung woman from Northern New South Wales. Emma is not only just a fearless leader here at the UCRH and the University of Sydney, but she is well respected and acknowledged within many other communities across the country. So welcome to Emma. Yeah. Thanks, Trace. Yeah.
Okay, so my PowerPoint's not working. Happy Monday. Why don't you just put it on the thing? Oh, you might just have to hear me flap my gums and don't worry about any pictures. Yeah, probably. I just think it'll take a long time. You don't really need, that's right. You don't really need, I can just talk, if that's all right with everybody. Morning, welcome, come on in. Yeah. Hi, everyone. Yeah, apologies, because apparently my slides are not going to work. We might chuck this thing out. So my name's Emma Walk. I'm a Yangibal Bundjalung woman. My family from Ballina, Cabotry Island, and today, I'm the head of Indigenous Health for Sydney Medical School and the academic lead for Aboriginal Health here in Lismore. And very lucky to be able to work and live on country, really. For me, I feel very spoiled. So what I'm going to have a yarn with you about today is actually a project that I work on with Tracy, with Professor Megan Passy and Amal Chakraborty, who's in the room as well. And our project is called, it's a research project, and it's called The Voice. Somewhat unfortunate given the last year's worth or a couple of years worth of things, however, not related to that in any way. So VOICE actually stands for validating outcomes by including consumer experience. And so it's an acronym really, but what it is about is actually working with Aboriginal community control and Aboriginal health services around the country to develop a survey that actually is fit for purpose for Aboriginal health services. And where this comes from is actually through the accreditation process. So all general practices in Australia that get access to Medicare and also access to PIP payments need to go through a process of accreditation every 3 years. And every 3 years, a group of people come into your clinic and they look at everything. They look at your papers, they look at your patient files. They want to make sure that what you're doing is best practice for your clients. But what we know is that Aboriginal health services are much more than just a general practice, which is not to diminish that in any way, but it's more than that. And so usually it's a wraparound service. And so an accreditation survey really only looks at one point of time every 3 years for one small amount of patients in an Aboriginal service. So it doesn't really work. And so what we've done is we've got 8 different services around the country. So we work with Bullina in Ballina, where I come from, Werrin, which is Port Macquarie, Inala, where we're going this afternoon for our third visit, in Brisbane, Quatsich in Charleville, where we were last week, Congress in Alice Springs, Ngunnawal and Yunti in Adelaide, Pearl and Gympie, which is in the Tiwi Islands, and then Mindalang, which is in East Arnhem Land. And they're all different services. So some are community controlled, some are government run, some are moving towards transition into community control. So they're all in various sort of stages, and they all have different ways of doing their business. And what we're trying to do is make sure that this survey is going to be useful for all of the services and the way they run their organisations, wherever they happen to be. And hopefully, well, we're supported by RACGP, and Veronica also works on this project with us. RACGP are kind of supporting us. They're the accreditation body. So we've got really good support from them, and also from the Australian Health Quality Services, AXA Australia. So what I was going to do is just have a brief yarn with you about where we're at with the project. This is the first time we're really presenting outside the community. And so what we've done is we've been to the communities, all the communities at least twice. First time around was just to get to know people. Second time was to talk to community and to staff. There's two different surveys or processes that we've used. And then in between then and now, we've actually been through a process of analysis. So I'm just going to talk about the community data. And what's happened with the community data is that we talked to over 160 people. So a lot of people, a lot of conversations, open-ended conversations, not, specific like dot question answers. And so that data all came back and we all had a look at that. And then we brought it down into kind of a, when I say manageable, more than 100 kind of statements that people had made that was consistent across all of the different sites, or that was across all the different sites. And then our advisory group, it's made up of more than 20 Aboriginal people from around the country, got a chance to look at that data twice. So once early last year, once late last year, and they brought it down to a whole series of kind of themes, I suppose. And then 4 of us came together. So myself, Tracy, Roxanne Bainbridge, and Annie Nalita from Alice Springs. We kind of looked at that data from an Aboriginal perspective and tried to make it work, or not tried to make it work, tried to sort of develop a story from what people had told us. So our story sort of starts from a community perspective. Now what we're doing is going back and showing everybody what we've found and checking that actually what we've kind of come to in analysis is what they agree to. Is it right? Is it wrong? Did we miss it? Are we losing our minds? Whatever. So essentially, the story starts with what community really want from a medical service is this kind of overarching space to be well, and that actually that happens through the service themselves caring for the community that they work in. And so that's kind of the overarching theme that comes out of every single conversation we've had with community members. Then we sort of split it into broke it into 4 categories underneath that. And when it's not really a category, but the idea is that these concepts actually tell this story of how the services look after their mob. And so the first one is actually about access. So access is really important to people across the country. And when we're talking about access, there's lots of different types of access. So some of that is about the community having choice about the sorts of services that they have. And how those services are delivered and where those services are delivered. So, for example, if a lot of people felt like they wanted to have service on country, they wanted to be able to be at home sometimes, and they wanted to be able to have home visits, and that in some communities was really important, particularly when there was those kind of people are really unwell and they couldn't get to the service. Being able to have access to healthcare in their homes was important, and that's not just physically. Sometimes people talked about phone conversations, but the majority was physically. Access in the sense that if they couldn't get somewhere, that they were able to get transport. In some communities, the health service is sort of 200 metres away from where everybody lives, but they might not necessarily want to be in that space. So being able to go there is great, being able to get there is great, but also making sure that service can come to them is really important. Access from a perspective of what the building feels like, the space, whether it's open and welcoming, and that actually is another whole theme in it of itself. But how people felt about using that space, whether people could access it if they were, in a wheelchair, whether people could access it if they were away from town. So in the cities, for example, a lot of people live quite away from the health services. So how do they get to them? And how does the service make sure that they can access that? And in some cases, services aren't responsible, but some cases they are. So that's the first kind of theme. And the second theme is around the space being a part of the community and the community being a part of that health service. So it's this important connection. And so that connection includes things like people just not being unwell, but being able to go to the service and have a yarn with anybody they want or have a cup of tea, or that the service provides community events or, open events that actually aren't related to technical or physical health. It's actually just more about being a place of connection. That the service understands the cultural aspects of that community. And that, again, that the space is open, it's welcoming, that people don't feel judged when they walk through the front door, which is a huge issue for a lot of people, especially when people are living off country. and they don't come from that area and they want to go to a service, they don't want to feel like they're an outsider. They want to feel like this service is a part of them as much as they are a part of the service. And a lot of people we spoke to weren't board members. We did speak to board members, but they were just a part of the community. And so they just wanted to know that when they went to the service, they were safe and they were welcomed. The third one is about knowledge. And, knowledge is power, really. And so a part of that knowledge is actually about knowing what the service provides, how the service provides it, and if you need something, how you can access it. But also the service knowing about the community, talking to the community, being in good communication. There's good communication lines. And there are places where that wasn't necessarily the case, but it was still very important to the community to know that. And also the thing about knowledge is that people need to understand what's happening with their own healthcare. And if they don't understand what's happening, then they're actually disempowered. And so community people did talk about the fact that they wanted to understand. They didn't want jargon. They want to understand what's happening. And not just that individual, but also the family that sits around that individual, the people who are involved in their care. And then the final theme is actually about systems. So things like IT systems. So internally, community members or the clients really wanted to know that when they went to a service, they didn't have to repeat themselves, that the service knew what's happening for them, that they had a system in place to remind them if they were missing appointments or if they were going to have an appointment, that there was no time lag between, or as little time lag as possible between when they saw a doctor, for example, and then they had a second appointment with someone else or a specialist or a allied health person or whatever, that they really needed to make sure that there was not a long lag between, because otherwise people disconnect from that and then they leave, especially if it's confronting. People are more likely to pretend it's not happening. They need to have that conversation. And I think the other part, waiting times always comes up. And I mean, everybody hates sitting in the doctor's waiting, but it did come up. It wasn't a major thing. I was really surprised about that. But it did come up as a part of the conversation. People don't want to sit in there for hours. And maybe that's linked to the fact that it didn't come up as much. It might be linked to how people feel connected. We haven't got there yet, but how people feel connected to the service. That's all right. You can sit in there and have a yarn with your cousin or your auntie or somebody at reception or a health worker. People sort of didn't seem to have too much of a problem, but they didn't really want to wait a long, long time. So definitely hospital conversations came up, which was not what this was about. The hospital conversations came up around wait times and people leaving if they felt like they hadn't been looked at or hadn't been seen. And that's probably the last thing I'll add before I stop flapping my gums, is that people really felt the need to be heard. They just wanted people to see them and to hear them. And I think that's really important to consider. But just as a bit of a link to the staff data, is that staff was one of the major things that came through our staff data, was hearing from the staff that they knew that their mobs, they needed to be heard, they needed to be seen, and they needed to be respected. And so, yeah, that's where we're at with this data. So in terms of what's going to happen now is we've got staff data which we've been working on and sharing back to communities, which we have been doing this last few weeks. We've got a few more visits to go, and then what comes out of this yarn is actually we're anything we've missed or people feel we've missed, we're adding to that. Then we'll bring it back for more discussion between the team. And then we are working with a lady who is fabulous at developing surveys. And she thinks about things in a really particular way, and it's so interesting. So she's going to help us develop the survey, and then we're going to take them back to the community and have a conversation with the community and say, does this work? How does this work? And probably one other thing is, how does it work? In terms of how do people in each community want the data collected? Some communities, adamant, we just need to have yarns. Some communities, no, I'm fine. I'm happy to press a button on the way out the door, or happy for you to send me a text. So that's another part of this study that's really, really interesting, and across country, quite different. So I'll leave it at that. If anyone had any questions. Did you want questions now or do you want questions later? Yeah. Yep. So the question was from Dave Edwards, and it was about did we see anything that stood out that was different from a mainstream general practice? Oh, look, I think the fact that people feel like they own the service, community feels like they own the service, and I think that's quite different. I mean, I might be wrong, but I think that's quite different. You know, I think it's the service as a word really is like a tool, but I think people really consider a service like a home space, a space to feel comfortable and connected. And so it's more than just their physical healthcare. It's kind of that, you know, when I'm on this space, like when I come to work, when I'm on this space, I feel comfortable here. That's how they feel. And it's that I can pretty much do whatever I want because it's mine. And that's what I think is quite different. Yeah, thanks for the question. Not sure if anybody had any questions online. Yes, Jack? Jack just asked how did we ask how community would like the data collected? Do you mean in terms of the survey itself, or when we went out there? Yeah. 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 Yeah, well, we actually just asked people, like every group we went to, we said, well, how do you know, if you were going to answer a survey, how would you do it? What's the best way for you? And like there was a discussion also had around the need for somebody who facilitates those conversations, particularly where English isn't the first language. And so it was interesting because we just said to people, how do you want to do it? And some people were like, well, I don't want to do a survey, or I don't like a 30-page survey. You know, I don't do IT. So some communities, particularly actually in Congress in Alice, there was the majority of people really just wanted to sit around and have a yarn to do it. Obviously, there are issues around how you collect that data and then how you manage that data afterwards, and that's more in the service yarn we'll have. But yeah, it's really interesting and it was quite different. Yeah, in each community. Did you have a question, please? Yeah, how we manage the data after collected. And I mean, this is still work we've got to do with the services, because I mean, given that there's probably 6 or 7 different ways to collect feedback, and also in terms of regularity. So not what we're going for is more than every 3 years. It's like more regular, but depending on the service, where they want it, how they want to do it. So then they need to have someone who can manage that data. They need to have someone who can analyze that data and then be able to present it back in a way that's palatable for the community as well as the service. Oh, who? In some instances, people sort of mentioned it, but they didn't pick out particular people. It was more kind of an open-ended sort of, we didn't ask them to pinpoint a person. Oh yeah, always confidentiality comes up as a conversation. But interestingly enough, confidentiality came up around things like basic feedback. So there's a difference between obviously feedback and then the survey that's going to happen. People see feedback and the survey as the same thing. So they think filling out a bit of paper and putting it in that suggestion box that technically no one in any service knows what that box is for or what happens to it. I can't even tell you how many people, even in the service staff, didn't know. People were more worried about that from a confidentiality perspective than they are about filling out a survey about their experience of care. So that's kind of interesting. Yeah. 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 So the question was whether or not paper-based versus digital. Yeah, it definitely came up. In some communities, they were really happy for the idea to have the digital stuff. In fact, the last one we went to, we were talking to people about our findings, and they were like, yeah, you could just send me a text and I'll just click on it and I could sit at home and fill it out. And I was, okay, that's cool. That's a really interesting, because some people are like, no, once I leave a service, it's done. I don't need to do that. I'd rather fill out a bit of paper, or someone can sit with me and do it. Yeah, so we've got some challenges there. Yeah. Yeah, so the question is from Vicky about whether or not do we need to provide different methods. I mean, I think logically or logistically we should, for every community that we end up working with or that ends up using this should have access to all of those tools, and then they can make it work, whatever's happening in their community. But yeah, it's definitely a challenge. For sure. And whether or not some services have really great like research, they have researchers embedded in them, but most of them don't. And so not having that means that there's this whole other side that we have to consider when we're coming through with the developing of the survey. Yeah.
Sorry, just
Yeah.
to add to that, within the small, we go to many smaller communities as well. So one of those, or two of those communities are in the Tiwi Islands. So Pearl and Gympie and Ninjalang. So at Pearl and Gympie, you have a community of maybe 60 people or something. So to have one whole designated person to do that would be quite burdensome on that service.
Sure. So one more question. Yeah. Yeah. Yep. Do you mean in terms of like physical space where people sit and have the conversations, do you mean, or? Yeah. Yeah. Yeah, no, that's a really good question. So just was a query about in particular sexual health and how you would manage that in people's discomfort or need for kind of safety, I suppose. I mean, I think the one thing about this survey is we're hoping that when it's developed, that actually we haven't really worked it out yet, but the idea that kind of those cartridges, there's kind of things that you include or don't include depending on what happens with that patient. But I also think some of the services we're happy to have like people to have these conversations outside, not in the building and not necessarily in a group setting. It could be one-on-one sort of conversations. And I think actually I will say in terms of the process, being able to talk to people the way we have done has been really good. People are very frank. I mean, the questions are really simple, like what's important to you in your healthcare? Tell us about an experience. It doesn't have to be positive or negative, or it could be either, it could be both. And so people just shared with us enormous amounts of things. And I think part of the process is about setting up that safe space at the beginning. Like this is between us. We're not going to put your name to anything. Everything you say is, we're happy to share it, but we're happy to not share it if you don't want. That just helps us make decisions. So I think it's about how you broach that subject. Maybe that might be the conversation. But letting people opt into these combos at the beginning has been great because so many people have shared with us lots. Yep. 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 No, I can understand. But I also think that safe space means that people are equal on an equal footing in that conversation. And yeah, I agree. I definitely people's literacy will improve if we're better at communicating what's going on. For sure. Absolutely. I think that's tough for services. Yep. Yeah. Not from community, but we have a whole lot of other data, which I'll probably present tomorrow. But yeah, there's definitely conversations around that. Yeah, absolutely. And this was around staff wellbeing. And we've got quite a lot of data from the staff. And there's one on the screen. What feedback are community giving about what's not working in the majority of services for their needs? It's interesting. So that's a good question. People think about that. I think the major issues that we've kind of come across, which is part of what we've found in the themes, is that knowledge is power stuff, is that where things aren't explained properly, people disengage or they have the wrong opinion about what's happening to them, or they the wrong opinion, but they don't understand what's going on. And so I think communication is probably one of the most important parts of, solving some of the issues that happen within the services for patients. And, I think the survey itself, if we do a good job, I mean, you could all chime in, but if we do a good job, hopefully the survey will be able to identify to the clinics or to the AMSs really quickly where there's an issue, and then the service can respond to it. And that's, I mean, we'll talk a bit more about that when I do the staff data at some point, but, you know, the idea of timeliness between giving your information and then what does the service actually do with what you gave them? Like there needs to be some, you know, time where, short time where the patients share something that is either really positive or really negative, and then they see a result because of it. Because if they don't, people are going to stop giving feedback, and you know it's the service's job to do that. It's really important. Yeah. Well, I think the locality of where the service is physically placed made a difference to what people said. So, for example, those communities sort of further away from a hospital like Pearl or Mindjalang, where people have, for example, kidney disease and they need to be on dialysis, they can't be at home. They actually have to be across the water in Darwin, and nobody can pay 2 lots of rent. So there was lots of conversation around people living in the long grass in Darwin and that's where their partners or husbands went, and then they ended up dying because, you know, nobody knew anything about it because there's just no access for them. So those types of things definitely came up. Things like health checks, or how people run their health checks, or how people run, their diabetes clinics, for example, differed from place to place. But people didn't necessarily talk about some people did, but as a whole, their health issues. They didn't. Some people did, but it wasn't kind of the main process. Yeah. Okay, that's me done. Thanks, everyone.
Thanks so much to Emma and everybody that had questions. That was a great discussion. I'd like to call up now another fearless leader, group of leaders, Associate Professor Veronica Matthews, Chris Vine and Taylor Laurie.
Yeah, thanks, Tracy. I just hope that yeah, give it a go. Yeah. Thanks, Tracy, and thanks, Miles, too, for the very lovely acknowledgement this morning. And the room looks absolutely amazing. You guys on Zoom, it's such a beautiful, decorative natives, yarning space here in the room. It's absolutely beautiful. So I'm Veronica. I'm a Quandamooka woman from Minjerribah, North Stradbroke Island, just off the coast of Brizzy. I've had the privilege of working on Bundjalung country for the last 7 years or so. So I would also like to add my acknowledgement and pay my respect to elders, past and present, and any First Nations people here in the room or online. So we're here today to yarn to you about CRE Stride, which is a big collaboration of people that spreads nationally. And underneath Stride, we have a whole range of research projects happening, such as Voice, which you heard from just recently from Emma. It was a very good question, Trace, that you put forward to us about what does Reconciliation Week mean to us. And for me, I think the theme is very pertinent now more than ever, given what happened last year with the voice referendum. I personally was quite devastated, as a number of our mob were. And it really did consolidate a lot of the thinking for me in terms of where we take our research directions. So we're going to talk a bit about that as well today. So Chris and I will touch on what is currently happening under Stride. I'm going to hand it over to T then to talk about the stuff that she does, the magical stuff that she does with research translation, which really makes us look truly deadly. So this is a portion of Stride. This was at our face-to-face last year in March up in Cairns. So they were looking pretty cold back then, aren't we? Must have been an early winter. As I mentioned, we are a national collaboration made up of researchers, service providers, policymakers, and community members that are working to strengthen primary healthcare service delivery for mob. The heart of the collaboration sits here at UCRH. We're very proud of the fact that Stride is here, based rurally. We're at a stage where half of our investigator team are First Nations, and that the growth in Aboriginal and Torres Strait Islander leadership has been an important part of the Stride story, and it's something that we do continue to work on and to grow. It's important to honour the history, where from where this collaboration has come from. So it's 20 years of research work that's focused on primary healthcare system strengthening through quality improvement processes. So that's the clinical audit and feedback type processes that have been designed with Aboriginal and Torres Strait Islander communities across the country. So Stride is, as I mentioned, the latest iteration of this research collaboration. We do finish up at the end of the year. We continue this vision of equitable healthcare for First Nations community by working collaboratively with services around the comprehensive model of care that is very unique to community controlled health services. So as Emma was just describing how holistic that model is, we also focus on the systems that support that the delivery of that holistic model of care. And that could be governance models or workforce strategies. So prior to Stride, our research focus was a bit clinically focused, but with the First Nations leadership, we have extended the scope of our research out to include more the social, cultural, environmental determinants of health, but importantly centered our research in community. So getting community more involved in designing our research agenda, getting more involved in the actual implementation of the research, but also the translation of the research as well. So this is our long-term challenge, the gap in health outcomes, which has largely been attributed to social and economic determinants of health, and then the associated health risk factors that play out from that inequity. There is an unexplained part, just because we don't have the data, but we know that a lot of it is due to cultural, political, environmental determinants that often don't get factored into health policy practice or policy. And that is, the fact that our mob face systemic racism, everyday discrimination, the fact that we have no control or lack the decision-making power around what happens with our communities, a lack of access to country and seeing country sick, basically from climate change. And these determinants are also labelled settler colonial determinants of health, because largely they do stem from colonisation. So that's poverty, dispossession, at their roots, the powerlessness of communities, which are all fundamental drivers of our health. So the Stride research framework really honours Indigenous ways of knowing, being and doing. It brings to the core or foregrounds our principles of relationality, thinking holistically, respecting Aboriginal and Torres Strait Islander knowledges, knowing that they have an important place alongside Western knowledges. We take a all teach or learn approach to our research. We honour and value everybody's wisdom. It's not just about what the academic knows, but service providers, community people, Indigenous, non-Indigenous alike. We all have an important contribution to make to our research. Knowing that we need collaboration and partnership in the work that we do, we're attempting to solve complex problems, so we do need that intersectoral and multidisciplinary partnerships. Sharing knowledge and information in appropriate ways, so honouring Indigenous data sovereignty in that, as well as our Indigenous cultural and intellectual property, but ensuring that our research is also impactful. So we want to be able to make change, and I think the best way to do that is from the ground up, so place-based processes that take into account community context. As I mentioned at the start, the Stride research is very diverse and there's a lot of it. And we don't have a lot of time, obviously, to go into every project that we do, but we have just chosen a couple of examples here to highlight, and all of these operate here on Bundjalung country. So going back to 2018, prior to Stride even beginning, the UCRH Aboriginal staff here led a community consultation process called Grassroots, and we wanted to yarn to community about what their visions were for a healthy future, and that ended up with this poster up on the screen. And what would it take for us to get to that vision of a healthy future? And as you can see, it's all very strengths-based. It's all about connecting back to culture, getting on country, being together as a community, having responsive AMSs, which the Voice Project speaks to. And I think we're doing quite well in that agenda within Stride. I think we're ticking off a number of these areas within the Stride research program here on Bundjalung country, which is something that we're all pretty proud of. The Voice Project, which you've heard of from Emma just recently. We've also got a workforce project for working it out together, where we're working with community members around the design of innovative workforce models. So it's not only about the staff that come to the community, but it's also about growing our own. So to strengthen the workforce stability, particularly in rural and remote locations, and healing country, which Chris will talk about in a minute. But it's just wanted to make the point that all of our research is place-based. It's solutions focused, it involves community, and we're working to transform systems that really don't work for us.
That's a great lead in, I think, to talking about this project, Healing Country, which I know many of you are familiar with, but some may not be. So I'm lucky enough to get to tell you all about it. So Healing Country, ARC 4-year funded project, is really looking at climate change impacts and how that's impacting communities' health and countries' health. And we're looking at that from a holistic health model, like it's been talked about already today. So it's respectfully gathering traditional knowledges and working alongside Western knowledges, so hence the weaving of knowledge systems together. It's co-developing a couple of tools. So one aspect will be developing almost like a decision-making online interactive tool called story data mapping. So that's layering environmental health data alongside and equally alongside narrative data that's coming from communities about what they're seeing in their country, what changes they're seeing, how that's impacting community and family health holistically. The other tool that will come out of this project is more an advocacy tool, so a climate action plans around implementing strategies that the community have developed in order to address some of those climate worries that we're learning about through yarnings on community. And both of those tools, the online interactive story data map and the action plans, will live well beyond the Healing Country project because it's owned and developed by community and community members who are working already in this space and have great interest in the health of country and the health of communities. And alongside that, we'll also be developing like resources and approaches of how to monitor and evaluate those strategies as they're implemented by community as well. So really a whole lot of capacity strengthening there for tools and resources that can go beyond Healing Country and into all different sectors of where the community want to work. So we're working across 3 diverse different sites, and I think that's honouring what Veronica was just talking about, being place-based, because we acknowledge that every community is unique in its own ways, but also so is every country and environment. So we are working on Bundjalung country, and across the ways over in Perth on Wujak with a community partner there called Telethon Kids Institute. Here it's Jargon Alliance, the Aboriginal Corporation, and also with the Warramunga community in Northern Territory in Tennant Creek, working with a community partner there as well, which I'm going to talk a little bit more about today. So Warramunga community, I suppose what this example talks about is that it really shows what co-design and community-led research can look like. In Warramunga community in Tennant Creek in the Northern Territory, the elders have already determined what their real climate worries are, which is around heat and housing. Now we know from environmental data that heat waves are becoming and are projected to become much more severe and much more frequent in Central Australia. And the community is saying that housing that they're living in is completely inappropriate, both in terms of the environment that they're living in and also the ways that they want to live and should be living according to culture. So Willia Junta has been created and led by Warramunga elders, and it stands for Standing Strong. I think what we've been honoured with is that Healing Country has been invited to come and work alongside Willia Junta to record their story and evaluate the work that's happening with them. So these pictures are a great example of all the co-design that's happening with input from architects and engineers and service providers like energy providers. And there's some of the Willia Junta members there you can see having conversations about models of the homes. Now these homes are developed for each family's needs, which isn't particularly revolutionary, right? Like that's how we design our homes. The first thing you'll be asked is, what are your needs? What are your family's needs? What do you like? How do you interact with your space? And it's about time that community are asked the same questions. These quotes here sort of talk to that a bit more. You can see the first one there. We went in on January the 26th, we were invited significantly enough into Tennant Creek for Willia Junta to launch their collaborative on Warramunga country in Tennant Creek itself. So that first point there is really saying that for an elder to say that this is the first time that they've been asked what their home could look like or what they want from their home is an incredibly empowering yet sad state of affairs. The second quote there talks about the fact that what Willia Junta is for, what it's trying to do, it's trying to live our way and build better houses for our way of living. Not only for the Barkly, but for the whole of the country. The generosity of spirit amongst the communities we work with are incredible. So that people can have their own choice on how they live and how they have their house. It's culturally and appropriate and also for holistic well-being. So one of the aspects of Willia Junta is that it has a huge potential for impact. If these homes can be developed, these homes will be developed and built on country that is owned by community in a way that community want it and a way that's appropriate for the health, for the climate of that space and the climate that's to come, as we know with the projections that are coming. It has the potential to impact the health and well-being of those families and communities for generations to come. And what I suppose Healing Country is there to do is to record, document, and provide the evidence of what those impacts are. And then again, that's communities' information, that's communities' data, that's the tool that community can use to say that this is the right ways of doing. And I think it's also a great example of this project of showing the right ways of doing research as well, being invited into this project that is designed and run by community, making an impact, making difference, and providing that evidence base back to community to keep doing greater things while really honouring traditional knowledges on equal standing alongside Western information. Over to you, Jen.
Thank you. Hi, I'm Ginigay. My name is Taylor Laurie. I'm a Yagal Gumbaynggirr researcher, and I have a very big privy of working with both Chris and V. My role has become a role that's really based around communications and media and data translation and yeah, carrying stories through projects and making that a guiding principle or a way of us approaching our work. So this is, yeah, going to be a yarn for me because I love my research work and I love doing translation. But yeah, just a couple of examples of how data translation can really help to influence policy and really help to communicate different ways of being, doing and knowing and connecting and how valuable those differences are. And yeah, giving an example of what strengths-based work looks like and how everybody can jump on board with that and undertake that work alongside us. I'm pretty sure my video is next. So as Chris was saying, and Veronica, we went out on a trip and I was very honoured to be able to go out with the mob and we looked at all these different houses and spent time with communities and landed in Alice, drove to Tennant, met the crew there, then drove up to Barrapunta over a couple of days and backs. But yeah, being able to spend time on country and being able to record that was a very big thing for me. And to bring it back and consolidate it so it's a standalone resource that we can be using that breaks down what it is to be a researcher in the field and what that looks like, and making research much more accessible and a little bit more fun than how it presents outwardly, because it's all deadly, but to really engage you know, a whole next gen of young people and young minds in research, and you know, how can we best do that? So I'll flip to next. Enjoy. Bingo. I'm like, what? So I think my biggest approach for any of the work that I undertake with being gifted stories and then turning them into resources and bridging that gap between yeah, you know, white paper and black word based publications into something graphic and meaningful to mob is that I want mob to see themselves reflected in the work that we're outputting, and that's really important for any kind of meaningful engagement, especially when it comes to research and mob, given we have a really big historical context of mistrust and suspicion, and so yeah, it's important, and I love being able to do the work that I do. And I decided to make the slide a bit different. So a face that I don't recognize can pick out one of these data translation outputs, and then we're going to yarn about it because it's the same process, but then it's also, they're all based on different stories, and whether that's locally or from mob out west and up north, yeah, is important. So I'm either going to go one of the Acon crew or you two ladies, because I'm not familiar with you. I'm not sure now, actual. I might, yeah, scissors, paper, rock between the group. I'll go you with the blackfellow deadly top. And I'm pretty sure on your badge it said Guy when you walk past. Yeah, we're gonna go you. Which one do you want to pick? Deadly. Okie dokie. So that was a trip that I did with the WOM crew. It's a project that's run out of JCU, and it's a project that focuses on how positively impactful mums and bubs groups are to mums and bubs health, to maternal health. That was a session we did up at Mullingu, up at the service up that way. And poster one is a conversation pre-Auntie Made Lunch, and that was the deadliest lunch too. And then poster two was the session yarn that came after the deadly lunch. This, both posters do explore themes of what's empowering, what's important to consider, what's the process. Poster one is also a bit of how we kicked off our day together, how did we start connecting, and what were some really, really important pit stops to make along that connecting journey. So a whole bunch of different mob coming up that way and taking different mums and bubs from different services and regions. That was deadly to sit down and yarn, and there were some lovely little babies there. And then poster two was looking at the process of how they made health yarns more accessible, and how did they bring in their midwives and their nurses further into that cultural practice of birthing and of being pregnant. And yeah, looking at how health services bridge gaps with the women. What did it mean for mums and bubs groups? The top right, the circle, that was different layers of community interactions and strengths that they could draw from the mums and bubs groups. The light blue circles around that are things that they combated, like loneliness, increased wellbeing, strengthening identity and culture in that process, as well as feeling like you're an individual in motherhood as well, that you're not just mum, you also can take space for yourself and sit with your titters, do your nails, get your hair done, go out for a movie as a group. So it's all inclusive of you are still an individual in this, and that's a really big strength base, given that we're very collectivist as people. But also things that we contended against. So in the top left, it was representation, and that was really important. So they combated that with the little camera stand light, and that was them doing a slide.
Into projects and then takes them into a story and doesn't.
I could just send an email out about
Saw that.
reconciliation. Great, you can say I attended the blah, and can people
Guys,
access the recording?
Someone's not muted.
Niall. Hi, Niall. How you going, cuz? We just might get you to mute. Thank you very much.
While we're interrupted, I think it's worth noting too, these posters 1 and 2, Taylor is scribing during the sessions. So these are basically
Live
notes of a meeting and
Yeah.
a big yarn and workshop. So it's incredible work.
Yeah, and it took a little bit to transcribe from paper because I can't read my own writing sometimes. But yeah, and that camera stand with the flashy little thingy majig, that was a photo shoot that the mums did while they were pregnant or with newborn bubbers with their midwives, and they all got oka'd up, and it was out on country. So it was a really lovely process of bringing and I guess bringing awareness to how culture and place-based practices and involvement and engagement really helps in a hospital setting as well, with midwives and nurses who are trained very clinically. So it was nice to cross that gap and to be able to then transcribe it into a graphic to send back to the services, and to have that reflecting the space that the dubs up there have created was a really big honor. So yeah, it was deadly. So all the approaches that I do take and we take collectively, always based around yarns and feeling. And so that's really weird for people to be like, well, what's your method of creating? I yarn and I feel, and I try and put that into something. So it's a very abstract thing for research, but we have a lot of fun and they turn out deadly, and I'm trusted enough to do my own thing in my own space. So I'm really thankful for that. So thank you, Kai. Do we have any questions? Oh, okay. It happens to the best of us, Niall. Oh, what if you want to? I don't- oh. Definitely. Yeah, and like V was saying earlier with Stride, this is our response to a failed referendum, and this is the next step for us mob that's been in this research network, and it's moving into Staunch, which is slick. It's a research network that's 100% First Nations led and advocated for. So it's a way of us being able to collectively also help mob in strengthening up and building their own advocacy practices. And there was a really having different structures. I might get V in to help me with this one actually, because it's very big. But it's also us helping to create space, I suppose, and give and help mob to bring back that power and fully embody that when it comes to decision making, when it comes to agency and data sovereignty. So it's a big process, and it's all very based in culture and nation building. Yeah, I might give V to yarn about nation building.
T, you did an awesome job, eh? I don't think I really have to add that much. Only to say that that diagram is another one of T's creations. It's just it's amazing when you sit down with T and you yarn about a concept and something so beautiful comes back. You know, you really do have a gift. So Staunch. It is nation building. At its basic, it's about shifting power back to First Nations mob. So working with communities, we have about 5 communities that we've identified for this next phase of our research. I should say that we've just put in a funding grant for this, so we don't know if it's going to be successful or not. But we're hoping that this will be the next stage of Stride. I mentioned that Stride finishes up this year. So we have 5 communities identified, Bunjalung again being one of them. And it's about working with local mob to really help them organise. So to get strong together so that they can negotiate with other governments. They have the cultural legitimacy and authority to do that. And start, and just make demands for what they want to see happen on their country. And part of that is strategizing too. So developing up health and wellbeing plans with community, so they have a forward agenda to take to government. But at the same time as well, we need to start working with governments about the way that they work with communities. We need new relationship-based approaches. And part of that is also, it's very difficult, but trying to get them to think holistically and work intersectorially. But we have plans to do this. It's ambitious. I should point out the Lower Chair Institute have put out a discussion paper on nation building last year or the year before. So I recommend you have a read of that. Yeah, I think that's all. So. Yeah, I suppose it's not about us selecting, it's about relationships and project ideas just don't come out of thin air. You know, we have these relationships with a number of different communities across the country, and often they come from previous projects as well. Like the voice project's been hanging around for a long time. It's just, it took us this long to actually get the funding to do it. But all of our research ideas are pretty much based on what comes from community. So in that sense, it's self-selecting in a way. Yeah. Hence the importance of relationships.
Great question, because there are big plans. The question was, is there plans to evaluate once village junta members are living in their homes that are being designed at the moment? We've actually just submitted 2 weeks ago a great funding application to address that exact question. But yes, that will be built into Healing Country regardless of the outcomes of that funding. That would just allow for a much longer term evaluation approach. But so we're collecting pre-information now. We're having yarns now about where people are at in terms of health and wellbeing and what the current living conditions are. And then the plan is to then look at comparatives of townhomes, which are government designed and delivered, Bessa block homes, for better part of the word, and then comparing them to the Wheelia Junta homes that are hopefully at least one will be built later in this year. So based on those relationships that Veronica was mentioning, we have no intention of going anywhere with this partnership and plan to be sticking around and having yarns and collecting as much information as we can. But yes, longevity would rely on some more funding to extend outside of where Healing Country sits, which is only another 2 years. So yeah, good question there, and hopefully we'll be up here talking lots more about it over the years as we're collecting that evidence base of how these things should be done. Thanks.
Yes, and we can make the slides available as well, send them around. Thanks. So you meaning the research workforce? Yeah. We are doing an evaluation of CRE Stride. So particularly around, there is a focus around the growth in First Nations leadership within the collaboration. So we are documenting the process and we'll be sharing that. Towards the end of this year, I guess, or early next year in Stride ends. But yeah, lots of lessons to share. That's the important part, isn't it? Yeah, but I think it is happening elsewhere as well. Like, you know, Stride is just an example of a growth of fantastic Aboriginal leadership in the academic space. We've got OCA now, which is the National Network of Aboriginal and Torres Strait Islander Health Researchers. Yeah, it's fantastic to see that we are growing in numbers, and there's a younger generation coming through, which is fantastic. Yeah.
Thanks, everyone. We're running a little early, surprise, surprise. Which means we have longer for morning tea. So we might break now for morning tea and maybe come back about 11:45. That'd be great.
Uh, watching trainings for the Reconciliation Week. There's one on at 11, which I thought if you wanted to watch it together, we could, if you're interested. It's tokenist, ally, or accomplice theme, which I thought you would be pretty interested in. It goes from 11:30 to 1 o'clock.
Structures of white.
Mm. Hi. Yes, please. Yeah. Sorry? Hmm. Good spray paint. It's only 5 bucks. Yes, please. I can know. Yeah.
sometimes the mighty would move off the table.
Right.
Yeah, I didn't love it.
If you open up my Chrome, the link is in my email. For the 11:30 thing.
Can you send me the link to mine?
Yeah. Ebony or Lucille?
I just.
Yeah, Ebony email.
Content. Okay.
Yeah.
So you said 11, so would I have come for it?
You still do.
If
What is it? 45 minutes long.
Chris doesn't know what's going
Ah, sorry. It was in my calendar at 11 for some reason.
Hi, everybody. Welcome back to our next part of today's presentations. We've got Jack DeLacy from University of Sydney. He's a public health audiologist. So I'd like you to welcome him today.
Hi, everyone. As Tracy said, my name's Jack DeLacy. So my background is in audiology and public health. Today, I'm going to talk to you about my PhD work, which is focused on the social determinants of ear health and hearing. Before I begin, though, I'd like to acknowledge the traditional custodians of the lands that we're meeting on today, the Widjabul Waiable people of Bundjalung country. I recognise that their rich cultural heritage, knowledge systems and languages are sacred to the identity of this region. I don't know why that's changing. I'd also like to acknowledge that yesterday was National Sorry Day, a day that we reflect on policies and systems that continue to undermine Aboriginal ways of being and becoming. But I'd also like to recognise that we continue to see strength and resilience in Aboriginal communities around the country. And so I'd like to pay respect to elders past, present, and emerging, and extend that respect to all Aboriginal and Torres Strait Islander people in the room. So I'd just like to preface that this presentation begins with a tragic story, but I want to emphasize that whenever I'm talking about deficits, I'm talking about the underlying systems of colonization, and that deficits are not related in any way to Aboriginal ways of being and doing. And I'd also like to recognize that these ways of being and doing are where we see incredible strength and resilience. So I'd like to begin by talking about Mutija. So Mutija is a Murawari man, which means strong one or warrior. Sadly, Mutija died on the 15th of February 2018 at the age of 44 from a left temporal lobe abscess. The origin of this abscess was an ear infection in his left ear. This was untreated while he was in the care of Corrective Services New South Wales, an ear infection. So from a public health point of view, ear health is complicated, but an ear infection itself is simple to treat. It should not end up in someone dying. And so here is a quote from the coronial inquest into his death from his cousin. And it states, "More so from the disbelief and awe-inspiring questions that haunt us when we think of Mutija, when we see his totem, his moiety, when we listen to or tell Mutija's stories and hear his song breeze, we will look at his photo and not get any answers but a great sense of numbness, shock and loss. Mutija was a son, he was a brother, he was a father, he was a nephew and a cousin." So reports revealed that Mutija experienced middle ear infections throughout his whole life. This likely impacted upon his education, his social and emotional well-being, and limited his opportunity to thrive into adulthood. And it's important to highlight that there have been connections made between experiences of ear disease and contact with the justice system. And that suggests that Mutija's ear health himself may have contributed to his contact with the justice system. And it's important to highlight that it was not ear disease alone that resulted in Mutija's death. Rather, his death was the result of inequitable and broken systems that are underpinned by ongoing colonization. And this is an important story to tell, as this story demonstrates the worst outcomes of untreated ear disease. But also that it is not merely an isolated pathology. Ear disease is far too often a symptom of social, economic, political, and cultural determinants of health. And so I just want to emphasize the importance of hearing. For me, the ear is the most important organ in the body. It connects us to the world around us, connects us to each other. So we can see the devastating impact of lifelong ear disease. But if we have healthy ears, that allows us to make those connections. It allows us to hear the stories from our parents, from elders in the community. It allows us to hear music and want to dance. It brings us happiness and joy. Hearing is incredibly important to our whole lives. It's not just one of the senses. It's an important tool to thrive throughout life. And so that brings us to the work that I'm going to talk about today. So this all started with a scoping review of the social determinants of otitis media in Aboriginal and Torres Strait Islander children. So what we wanted to do was see what does the literature say about social determinants and otitis media. And what we found was that almost all of the literature, particularly in the introduction section where you're looking at the background, it'll talk about how important social determinants are to the existing inequities in otitis media within First Nations and Aboriginal and Torres Strait Islander children. However, none of those papers and studies showed any evaluated approaches to address those underlying determinants that they spoke about as being really important in those backgrounds and introduction. And so this is really the driver and was the trajectory or created the trajectory of my PhD work. So the aim of my thesis is to identify social determinants for ear health and hearing among Aboriginal and Torres Strait Islander children living in non-remote communities in New South Wales and embed those relevant findings into a co-created community-led model of care that targets the underlying determinants of ear health. And so that project is called Access, which I'm going to talk about on the next slide. There's a little bit of a diagram up there. It's a little bit confusing in a way, but essentially the PhD project was underpinned by a couple of research projects, one called Search and one called Heals. Again, I'll talk about that on the next slide. And this scoping review. And this information has been embedded in combination with community yarnings, quantitative data that we've collected, and a systematic review to help develop and implement the Access model of care. So the underpinning studies of this work is the Search study of environment on Aboriginal resilience and child health. So this is a largest cohort study of urban Aboriginal children to date. This is a community identified project where the communities that were involved identified that they wanted a cohort study that followed Aboriginal children from birth for at least 20 years and captured health outcome data as well as social determinants of health data. So data on living in crowded homes or living in healthy homes, living with parents or living in foster care, and then a number of other points of data. So Heals came about from Search. So one of the key priorities of the communities involved in Search was ear health and hearing. The other key focus that they wanted to focus on was housing. So the Heals project is called the Hearing, Ear Health, Speech and Language Services. It was all about providing improved access to services around ear health and hearing. So it included audiology services, speech and language services, and ENT surgery. Culturally safe access to services. Also cost-free services. One of the key outcomes of the Heals project to date has been the success of the project officers that supported families to book appointments, to go to appointments, giving them knowledge about if they were having grommet surgery, that they need to fast, and really supporting those families in their journey in accessing services. And that was really the origin of what became the Access project. So we recognized that there were benefits for this support person. And what we wanted to do was enhance that role so that they could also address some of the underlying determinants of ear disease. And so that then led us to Access, which my PhD focuses on the co-design and co-implementation of access, specifically the Access Child Health Navigator, which I'll talk about in a little bit. So Access stands for the Aboriginal Community Controlled Ear Health Support System, which is centered around a Child Health Navigator. So that Child Health Navigator is like the project officer I talked about, where they provide support for families in terms of translating knowledge, and that's bi-directional translation. So not just translating knowledge to families, translating knowledge to health providers, particularly mainstream health providers. It might be organizing transport. It might be linking families up with housing. It might be linking them up with any other relevant service. It might be going to an appointment with them to make sure that they feel safe in those spaces. Emma talked a bit earlier about how community controlled health spaces were like a home base for people. And what the Access Child Health Navigator can do in part is kind of bring that home base to mainstream services. Not entirely, but that's the idea. And this work has all been underpinned by co-creation. And so using co-creation as a sort of all-encompassing term. So when I say co-creation, that's co-design, co-implementation, co-evaluation, and co-translation. Whereas often we see studies that they might be co-designed. We have, or at least in part co-designed, where you have researchers that go in and say, you know, what do you need? And then they don't go back. So it's really making sure that every step along the process is community driven. And that's, you know, a big part of why Search and Heals before Access has been successful, because it's all been community led. So it's a very, very important underlying driver of this work. So our work being co-created meant that hearing what community has to say was really, really important. So we recognize that social determinants of ear health are really, really important, and community recognized that as well. So when we went into community, they weren't saying we need more antibiotics. They recognized that there are underlying systems that are impacting the kids in their community. One of the really important findings as well was that whenever community spoke about positive things, we could map them on to services that were provided by community controlled health services, or map them on to Aboriginal ways of being, doing, and knowing. And so we've got this diagram here, which is mapped onto a framework for addressing social and cultural determinants of health. And we mapped our themes from our yarning circles from our three communities, which was Tharawal in Campbelltown, Rivmed in Wagga, Orange in Orange. And we could see that if we had good ear health and hearing, that meant that this created a healthy foundation for life, including speech and language development, social and emotional well-being, behavior, education. However, otitis media ear disease meant that those things were significantly impacted. When we spoke about the importance of housing, we have one service that is a housing provider. They had used some of the Search and Heals data to become a housing provider. It was not a difficult process, but to date, they've at least provided 115 new homes that were culturally designed with community. And in that community, when people talked about the housing provided in that community, it was really positive. But if you spoke to people from the other two communities that did not have community controlled housing provision, it wasn't such a great story. One of the quotes that underscores that was from an AMS GP who stated, I mean, we've got clients that are living in a tent by the river. The tent was given to them by public housing because they couldn't give them a house. So you know it's a single mum and her kid living in a tent by the river. We've got to do better. So, you know, that's heartbreaking story. But what we're hoping is that we can draw upon the strengths that we see in Burrawal, that we're able to lobby and become a housing provider, to try and get those other communities to become housing providers too. Because we know that when it's delivered in a culturally safe way, communities know best how to do this. We see good outcomes. We have community members who talk about how amazing housing is, compared to communities who talk about, you know, being placed in motels, or when we have GPs that say that they saw a family with 15 people in a 3-bedroom house. You know, there are stark differences. And earlier talked about the importance of not just health service delivery, but the systems. So systems level thinking is really important. When we talked about holistic care, community controlled health services were delivering that really, really well. So when people talked about ear health workers within the community, they spoke about how awesome they were, how good they were, how knowledgeable they were, how much they knew more than when they'd gone to see a GP time and time again, saying, here's antibiotics, here's some antibiotics, here's some antibiotics. And the parents themselves know this is not enough. This, you know, we have to do more. And then health service access, so just having access to services. Community members talked about how good it was that, you know, community health services will provide transport, they'll provide funding, they provide cultural safety, they follow up with people. So there were community members that spoke about how, you know, they'll get letters back from an ENT saying, this person was booked in for surgery, but they didn't show up. So, you know, we're not going to see them anymore. And then they'll follow up on it and they'll say the reason that they didn't go is because they didn't have transport to get there, but the community wasn't notified. And if they had have been, they would have got, you know, organized transport, made sure that they were supported in that regard. And then there were quotes around the importance of hearing in culture. So elders of the future was a key theme that came up. So, you know, the kids in the community are elders of the future. And I have a quote that sums this up. Sorry, me searching my phone for my quotes. Okay, so here one parent quoted, "These kids are the elders of tomorrow, and we need to make sure that they're good and strong because they're going to be raising my great grandbabies." Other community members talked about the importance of being an oral culture and the importance of storytelling. I think the important takeaway here is that coming back to that scoping review that I talked about, community recognize that social determinants are important. And I think it's really interesting that often we see research saying community have lower health literacy, but every time I go into the community, I realize the health literacy it's very high. I can go in and talk about otitis media and a parent will know what that is. If I said that to a random person on the street, they would probably have no idea what I'm talking about. They not only recognize that, but they know that housing is relevant. These weren't things that I was saying to them for them to bring up. They know. So there's community knowledge, not just around cultural factors, but around really important medical factors. So one of the key takeaways is that community recognized social determinants is important, and that the systems surrounding the communities is typically where the deficits lie. And so what we want to do is overcome those deficits and think about things from a systems level approach. So we also collected data. So this data was collected with the search study. And we collected data on ear health and hearing outcomes. And sorry. I think I've given up on my notes. So the ear health and hearing data, what it showed was that for the whole cohort, about 30% of children had some form of otitis media. If you were 3 years or younger, it was about 50%. Okay, and this is a cross section as well. So meaning this, the children that showed up on the day and had healthy ears, that doesn't mean that last week they didn't. And that's one of the tricky things about otitis media is it fluctuates, it comes and goes. But so to have a cross section where 50% of children 3 years or younger presented with some form of otitis media also recognizes that this is not just an issue in remote communities where a lot of the data is. So up until this data, there wasn't a lot on non-remote communities and ear health and hearing. Associated factors. So we looked at associated factors with ear health and hearing. Crowded homes was a significant factor. So children living, essentially it was a linear correlation. The more children, the higher the prevalence ratio was of ear disease. Living in foster care versus with your parents. And so these are things that we'd previously, before we'd looked at this data, we'd gone into communities and asked about, and we had communities saying the kids that we're concerned about are those that live in crowded homes and those that are living in foster care. So even without this data, community knows. So coming back to the idea of the strength of knowledge of community. Attendance at childcare. So it's important to reiterate that identifying the associated factors doesn't mean you need to take kids out of childcare, because childcare has developmental benefits. But what it can do is it helps us to prioritize children. So this data is really helpful because it enabled us to say, well, who are the kids that might be at most risk of experiencing otitis media? And it was children based on age. So we know that those younger children were more likely to present with otitis media, children living in crowded homes, children living in foster care, children attending childcare. There were the key factors. And again, this emphasizes that, other than age, these are social determinants of health. And so, as I mentioned before, the access, I'll be quick. So the access project was built upon or focused on a child health navigator. And so we've done a systematic review looking at health navigators supporting First Nations youth populations from a global point of view. And there isn't much literature out there, basically. We know that Aboriginal health workers do this role. It's just not documented or evaluated and documented. And so out of the data that we did have, we found that there was some important sort of guiding principles, which were, these models of care need to be social determinants of health focused, community-led, focus on integrating services in the community. And also that where these models of care had been embedded, they were largely positive. So there weren't any projects that had been evaluated that said this model of care does not work or found no association with an improvement. So all of this information has been sort of fed into the Access Child Health Navigator. So this is a timeline and all the different activities that have been involved in Access, and this has been reported in a protocol so that a similar sort of approach can be adapted to different settings. So importantly, it includes co-creation methodologies to make sure that it's community adapted. But this involves population level surveillance with data linkage, economic evaluation of the effectiveness of the Child Health Navigator, health outcomes, ear health and hearing, and also appointment attendance, things like, less emergency department contact, and increased appointment attendance where we're actually facilitating transport, we're providing cost support, etc. So to try and wrap up quickly, a key summary is that some of the key findings is that we know that social determinants of health are important. And so to embed these into models of care is critical. And when we do that, we improve access, we improve cultural safety, and we improve hearing. And hearing is the tool that gives us the opportunity to thrive into adulthood. And so I will I'll skip this slide, but I might just comment on it briefly. I've been very privileged to be able to work with the communities that I work with and learn from the elders that have supported me. And I always try to emphasize that best practice models are Aboriginal models of care, Aboriginal ways of doing research. And, you know, I've been very fortunate to be able to be involved in that. And yeah, I really hope that we can translate the work that's been done so far into sustainable solutions and solutions in broad communities as well. That's my dog.
Thanks so much, Jack. Anyone that knows me knows I love dogs, so you're a winner for me. Does anyone have any questions for Jack? Hang on.
Yeah, that's a really good question. My dog's name is Isla. I can answer that one very easily. Yes, she just had a bath. Yeah, I think that's a really important question. I think the translation, there's a lot of different parts of the translation. I think one of them is in knowledge translation for families. And I think involving children is really, really important. So we have yarning circles planned to go back in and ask them about exactly these questions. And so we'll be asking them, what do they want to see in translation? So every step of the research has been sort of initial consultation to say, you know, how should we approach this? And we're sort of heading into, we're now wrapping up data collection, which includes sort of implementation and evaluation data. And we're going to start moving into that translation. I think it's really important to actually capture the perspectives of children because we don't have that yet in this research. And there's not really any research in ear health or hearing that I know is actually captured the perspectives of children and, you know, how even just, you know, what does hearing mean to you? You know, does it help you in class? Or what messages might resonate with them? Yeah, I think that's really, really important. That's a really good question. I have a quote somewhere, but I mean, roughly before they introduced the HEALS project. So the HEALS project was really, really effective because we had children, I think some on average, maybe it was 400 and something days, quite a long time. There was one case where there was a child that was on a waiting list for something like 4 years. Yeah. Yeah, that's not uncommon. One of the challenges is that initially HEALS was funded through the New South Wales Ministry of Health. In the communities where it was implemented, they got rid of the waiting list. There was no waiting list, and they said, "Oh, there's no problem anymore," and so funding got cut. We've only been able to continue that project because a very generous person had heard about the project and donated money. And so we've got funding up until 2025. And what we're doing is trying to work really hard to harness that data to say to New South Wales Health, Ministry of Health, we need to reinstate this project and keep it going. It's been really successful, and we don't just want it in 3 communities, we want it in all communities.
Anyone else? No. So the data that's been analyzed so far is just phase 1 data. We do have phase 2 data, and we want to look at that longitudinal data. The tricky thing, it's actually statistically really tricky to identify who are we looking at point 1 as the at-risk child, because sort of, as I mentioned before, are we just looking at one time point where we've got an otitis media diagnosis or hearing loss diagnosis? Are they actually the children who were the at-risk child? Because you might have a child who's never had an ear infection before and just happened to have that on the day, and the opposite. And so what we want to do is look at some of the risk factors that we've identified, and rather than having, I think this is what we're going to do anyway, rather than having that single diagnosis as the group of children to follow up at that later time point, it's children we identify as at risk. So even if they have, they might have no otitis media on the day, but they might have had a history of otitis media. So that's one of the questions is, do you have a history of otitis media? How many times, etc. Do you live in crowded homes, etc., and all the other factors. So that's really important because that longitudinal data does not exist. Trying to think, there is some work being done in Western Australia that's starting to show those longitudinal outcomes. Speech and language is one, but again, that's a tricky one. And the tools that we use to assess speech and language, it's a lot of difficulty in actually getting precise information. Is this a valid tool? Often we're just using tools that exist, not necessarily ones that capture that. So there's a lot of work that needs to be done to really understand the longitudinal relationships. But I think it's really, really important. And yeah, so it's something I don't have an answer to, but I think it's one of the most important things that we need to do moving forward is try to get those longitudinal outcomes and do it. Funding. That's right. I mean, and that's the other tricky thing is that funding
often is in short blocks. To have funding over 20 years is difficult to get. The search data does show promise. We just need to get in there and do it. And again, there's not a lot of people in ear, health and hearing, even though it's a really prominent issue. If you work in ear health and hearing, you probably know every other person who works in ear health and hearing. And so, yeah, it would be good to get more people involved, and capacity building is really critical for that, particularly where there's a lot of deep community knowledge around ear health and hearing. That's a sort of resource that we need to really tap into. Yeah, so and I think it really comes around to identifying. So like a similar thing with transient homes as well. So even if you're living with parents but you're moving from home to home, I think that often makes prioritizing accessing health services difficult, or having a connection to a health service difficult. What we've sort of recognized, at least anecdotally, is that where we've got social and emotional wellbeing groups within the services that are actively connecting with kids in foster care in their community, they're getting them in to have their hearing checked. But if they're not connecting with the communities, then they're probably less likely to have their hearing checked and then receive the appropriate follow-up care. So it's really around that sort of not getting access to care. RivMed in Wagga, they've become a out-of-home care provider. So I think similarly to the housing provision in Tharawal, I think the more that we can provide that care from the community level, the less likely it is that there's going to be kids that fall under the radar and are not getting their health checks and are not well supported. So I think a lot of this work really is highlighting the importance of resourcing communities. Oh, what is Jack's name? My name is Jack. My name's Jack DeLacy. I work for Sydney Medical School in the Indigenous Health team. I also work for the Post Centre of Indigenous Health at Sydney Uni as well. Yeah, that's me.
Thanks, Jack. Thanks, everyone. Beg your pardon? Yes, everyone's slides today I will grab and send out to everybody. I'll sort yours out. Up next, we've got Candice Angelo. She'll be talking about the graduate diploma in Indigenous Health Promotion. Candice is also from the University of Sydney. Welcome.
and everybody. My name is Candice Angelo. I'm a proud UN woman. I am the program director of the Graduate Diploma in Indigenous Health Promotion at Sydney University. So we sit within the Sydney School of Public Health. I'm here today just to toot our own trumpet, I guess, and share some of the work that we do in leading the Graduate Diploma in Indigenous Health Promotion, and how we see it as a really important example of self-determination in practice, and just want to share our 25 years of success I would like to start by acknowledging the Widjabul people of this land. I also pay respects to the people, the Gadigal people of the Eora Nation, where most of my team sit, and also Yagal country, my sister Goa Taylor's country, which is where I do most of my work. I recognise the work that's been done there, and that learning and sharing has taken place in these lands since the beginning of time. Good news is I talk really quick, so hopefully we'll be back on track. So I guess just to start off with, some of you might know a little bit about the graduate diploma, but it was established in 1998. This is an Aboriginal developed postgraduate degree. We deliver it in 1 year, and it's a full-time block release program. So we teach 6 block intensives. We recognise that block intensives is a really culturally appropriate way of learning at a postgraduate level, because unlike other full-time university degrees where school learning is expected to be your #1 priority, we recognise that entry into our degree requires people to be working full-time. We also know that everybody comes to our degree with a full load of family, community and work obligations. And so block release, we've seen it being quite successful, because when people come to block, we learn as much as we possibly can together, and people have less obligations when they're with us in block, and then they go back to life and get back to their families and work and community and all of those sorts of things. So for that reason, our program currently, and has done for a very long time, graduates the highest number of Aboriginal and Torres Strait Islander students at Sydney University. I'm also really proud that my team is the biggest team of Aboriginal and Torres Strait Islander academics at the university. So I really do acknowledge the work of Jasper Garay, Karina Clarkson, Joel Dixon, Anthony Nichols and Tilly Peterson, who are the academics in my team. Without them, this program would not be as successful as it is. What we do in the graduate diploma is teach health prevention and harm minimisation. So we obviously do in-depth health promotion training, but we also touch on the wider public health concepts, health determinants of health, etc. So we teach across the spectrum of health and wellbeing issues, from chronic disease to holistic social and emotional wellbeing, across that whole spectrum of health and wellbeing. We focus on Aboriginal and Torres Strait Islander context in all of our teaching, in all of our blocks. We do provide pathways into higher education, and we're seeing more and more of that in the last few years, with students going on to do Masters by coursework, Masters of Philosophy Research and PhDs, which I'll touch on in a minute, because actually it might be some good news for Jack, related back to the question just earlier. Our graduates also are being remunerated for the work that they're already doing, because a lot of people come to our degree already doing the work, but without the qualification or the knowledge of the why they're doing it. So what we're doing is just giving them a new language for the work that they're already doing, and as a consequence, they're also being employed in higher positions and being remunerated appropriately. So as I said, we've been doing this for 25 years. The last 5 years, the degrees had quite a significant transformation, and that came about with Peter and Sandra Cadwallader, some philanthropists that left some money for our program to do some development, because they were really quite concerned about the alarming suicide rates in Aboriginal communities. So what we did with their donation was provide scholarships to bring more students in to do the degree without the HECS debt associated with doing a university degree. But we also did a lot of work on the way that we teach, and we made it more, we included more Indigenous pedagogy across all of our learning. So we've embedded a lot of on-country learning, for example, and we look at every health concept in a social and emotional wellbeing space, whereas before we were much more medical model, where we're trying to align with mainstream health. So I'm really proud to see that come to life, and as a result, the graduate diploma, we deliver 2 cohorts every year. So we deliver a full year cohort and a mid-year intake. We used to deliver one of our original grad dip cohorts and one of our social and emotional wellbeing cohorts, but we've just saw over the last few years that actually the way we work in Aboriginal and Torres Strait Islander health is with that social and emotional wellbeing and holistic lens. And so as such, we've kind of let the original grad dip go, and we just teach social and emotional wellbeing style of learning. So as I said, we teach 2 cohorts every year. We have our what we call our Sydney-based cohort. We found some success actually with teaching online when COVID came about. So this degree for 20 years was fully face-to-face. There's no online component. And of course, with the pandemic, we had to pivot very quickly like everybody else. And we developed an online version. We were concerned about that and accessibility for some people that are working with in rural and remote communities with bandwidth challenges, for example, but we've navigated that quite well. And we've had a really large influx of people that have actually said, we've been waiting for years for you to be able to deliver this online because I can't leave my community. So we do deliver our Sydney-based cohort in face-to-face and in an online mode. So we've got options there. And we also started a pilot program quite a few years ago now with Em and Dr. Michelle Dixon. We did a pilot program in 2017 where we delivered the grad dip here at the UCRH. It was a really successful model. We started that up again this year and we will be doing that. We'll keep doing that moving forward. So we're going to deliver a Sydney-based cohort and a Lismore-based cohort for the near future. Just a snapshot of just some of the places that our students come from. So we do see a lot of students coming from the East Coast of Australia, but we also have a number of students coming from all corners of this beautiful land. We actually were waiting for somebody from Tasmania to do the degree, but we did have somebody that's from Tasmania only last year. I haven't put enough pins on the board yet. So we do have grad dip alumni all across the country doing this amazing work, and a lot of representation in this new cohort from Tennant Creek, which is really nice. And we're seeing cohorts of students doing the degree together from workplaces, which is really a really good model, I think, having colleagues that are also doing the degree and that creating that cohort effect even in an online degree. So some of the core benefits, I suppose, for our students are that we think we deliver culturally appropriate learning. So our content is always culturally considered. It's delivered by a pretty incredible group of academics and an amazing non-Indigenous ally in Matilda Peterson. She's a prime example of an ally that we're really grateful to have working in our team. We also get guest lecturers that are doing great work in communities, so we're always grounded in the way that health promotion works on the ground. We always have culturally relevant engagement. So what we do is things like promote self-reflection as an assessment task. We understand the differences that exist across communities and encourage people to take the learning and embed it in their community ways of working. We also are enhancing pathways to higher education. So our degree is an AQF level 8, so it sits above the bachelor's level degree. So a lot of people, when they hear diploma, think of like a TAFE level, vocational education level diploma, but we're an AQF 8. So many students are pretty happy to hear that when they graduate, they're usually more qualified than their boss who has a bachelor's degree. And it's a really good stepping stone into a master's and a PhD. And we also have some really amazing networks and partners and stakeholders that we've built across time, and a really strong alumni network. So when people graduate from the degree, we always remain connected and share opportunities. Which brings me to the question before, Taylor, about that you asked Jack around getting the children's perspective. So Jack, who doesn't even know this yet, one of my recent students from the graduate diploma works in ear health in Newcastle Children's Hospital with Hong Kong. And she's been following your work, Jack, which is incredible, by the way. And she's interested in the patient journey. So has just enrolled in a Master of Philosophy, looking at the child's perspective in the patient experience. So building resources and things like that. So it feeds in really nicely to the work Jack's doing. And I'm definitely going to put you in touch with her, Jack. So yeah, there's a lot of that sort of sharing of knowledge and opportunities with people. When my academic team hear of opportunities, we know our students personally and what their interests are, what their work environment is, and we try to link people. And we've done that quite successfully for a number of years now. So this is just some pictures, examples, I guess, of what we do. So we had a cohort here, as I said, they literally finished last week, did their last block intensive, so they'll be graduating at the end of the year. And what we did was try to embed on-country experiences. So we teach the theory of health promotion and public health in a classroom setting. But we then go out on country and try to cement those theoretical concepts on the ground. So we show people. So we're not just telling people what to do, we're showing them. I've found that to be a pivotal turning point, I guess, in people's comprehension of the theory. If you can show them and you can tell them, it really helps people to understand, and we're going to continue to do that sort of thing. So one of the first block intensive, we teach students how to profile, how to do a community profile, and how to identify a community-led priority health issue. When we're trying to teach people how you write about a community, we then went out on country and said, this is what we're talking about. We want you to tell us about what's unique in your community, the plants, the flora, the fauna, the history, the culture, the lifestyle. So we're physically showing people what we want them to write about. And then here's some more pictures of my students on country up in the top left. The top right corner is my Sydney cohort, first face-to-face cohort post-pandemic, all together at the Gadigal Centre at Sydney Uni. The bottom left there is a recent graduation. We had a graduation 2 weeks ago. This is the one prior to that, just an example of how important Aboriginal and Torres Strait Islander graduates are for the field, but also how important their family are. We always like to get their family in because we know most people can't complete a degree without the support of others at home. So we're definitely grateful for everybody's family who supports them to get to this point. And then we have a Sydney-based cohort here. This is at the front of the Edward Ford building, which is where most of my team sit. So some of our achievements, this is the trumpet tooting. We've graduated over 350 Aboriginal and Torres Strait Islander students at the University of Sydney. We've ran for 25 consecutive years. Since 2020, we've delivered 2 cohorts every year. Prior to that, it was 1 cohort. Our cohort numbers have gone up significantly. So we used to teach really small classes of 8 to 12. Since the pandemic, when we went online, our online cohort this year, for example, has 53 students, and our face-to-face cohort had 14. So we're seeing an upward trajectory there of student enrolments. Also, workplace support is quite helpful. So when we see some really supportive workplaces that are leading the way and encouraging their employees to pursue further education, that also helps with the numbers. We've had a number of alumni of the grad dip go on to do masters by coursework, so Masters of Public Health or Masters of Philosophy, and we have some PhD graduates as well. And we've got this ever-increasing professional Aboriginal and Torres Strait Islander public health network. We also have quite a significant involvement in the Australian Health Promotion Association. And more recently, we're starting to see that our students, with the way that we're teaching, including on-country learning, it's increasing their academic grades. So some examples of that, I suppose, are one of our alumni was the most recent person awarded with the Sister Alison Bush Medal. And also for the last 2 years running, the Sydney University runs this Charles Perkins Oration Medals every year, which is awarded to the highest academically achieved graduates. And for the last 2 years in a row, there's 3 students every year. All of the students have been grad dip alumni. So we're producing the highest academically achieving students in university, which is really, really good to see that the way we're teaching is also changing the academic outputs. This is just a snapshot of what we teach. So as I said, we've got 6 block intensives. The middle column is our unit codes. And so we teach community profiling. Our second block intensive, we touch on health promotion program planning. And then we get into goals, objectives, and strategies. So students often do this really well. They just don't know why they're doing it. We teach people how to recognise the contributing factors to negative health outcomes and how to write health promotion programs to address those. Then we touch on some communication, which includes more modern ways of communicating about health promotion programs, so social media, for example. Then we get into research and evaluation. This is really it's a taste tester for students because often they finish their grad wanting to know what next. And we really encourage our students to think about research careers. So this is where we try and inspire students to think about going on and doing some research in their fields. And then we finish up with bringing it all together with students having a fully ready to run health promotion program at the end that's tailored to their community's identified priority health issue. And we also wrap up with teaching students about how health promotion is both an art and a science. So we teach the science, the theory of it, and we show them that their intricate knowledge of their community's needs is the art, and how actually in mainstream health, there's really good health promotion practitioners that get the science. The art is the hard part, and our students intrinsically are good at that. So it's a really nice wrap up for students to walk away from their 12 months with a fully functioning health promotion program that they can actually run in their workplace if they have support. And many students have gone on to run their health promotion programs in real life. We say that we're teaching a new language, so it's work that they're already doing. We're just giving them the tools and the terminology, the jargon, to be able to sit proudly at the table and feel confident in their place. So these are the units of study that we teach, and we try and translate it to what people are doing actually on the ground. So in our community profiling, what we're doing really is sharing Aboriginal and Torres Strait Islander community narratives and experiences and learning about their community. In our health promotion program planning unit, what we're really doing is learning health promotion theories behind the everyday actions and community life. In our goals, objectives, and strategies, we're adapting people's existing knowledge and just giving them the tools to write it up in a professional manner. In communication, we're enhancing engagement, navigating community work, and creative ways of sharing knowledge and information. A research and evaluation unit, we're understanding how research can work for communities and with communities, health services, and how to evaluate programs, because we hear people running programs are really good at the running, not so good at the evaluating. So we spend a significant amount of time learning together how to evaluate a program, which can be quite helpful if they want to go for funding, or if you want to see how successful something's been. It's really important to be evaluating. And then in our art, science, and politics, our last block intensive, what we're really doing is promoting realistic pathways into the future. We talk about public health in its wider context and let people pitch their ideas. So this is a skill we've embedded in the last couple of years, where instead of just presenting their health promotion program, we're getting them to pitch their idea to us, because that's often the nature of funding in health, is that it's competitive. So we're giving the students tools to be able to confidently pitch their programs, which is a skill that they can use in the real world. So we're a nationally recognised postgraduate degree, and this is just the best day of the year, of course, when students come from all over Australia to the hall and graduate all together. We also make sure that our academics are still actively involved in the field of health promotion. So we have a lot of health promotion programs that we run as an academic team to make sure that we're relevant and grounded in what's happening on the ground. So some examples are, we run health promotion programs in primary schools. Active Health is one of the programs we run, which is about teaching kids how to cook and how to use pantry ingredients to create something that's a little bit more healthy. And we also run programs on physical activity. And on the right side is a program that we were sort of commissioned, I suppose, to run. My colleague Jasper Garrow and I went out and ran a program in Canamble, which was about building the relationship and connection with the youth, with the justice system. So creating a healthy relationship between the police in the community and the children. So we ran all sorts of programs, but at the end of the program, we had a healthy competition of basketball game between the community kids and the cops, which was a really nice relationship building exercise. So we do run health promotion programs to make sure we are still grounded. And where to from here? So this is me at the Bachelor Institute. So where we're going now is thinking about how we can capture the harder to reach populations that need this degree. So we obviously have people that we like the low hanging fruit, ones that we can get in to do the degree, but there's a lot of people that really want to do the degree, but might not be able to come to us and might not be able to access the online version due to connectivity issues, bandwidth, etc. So what we're looking to do now is what we're calling reverse blocks, where we're bringing academic teams to the communities. One example of that is we've had some really quite in-depth conversations with the Bachelor in the Northern Territory and talking about bringing my academic team to Bachelor to train up their workers. Similarly, we're going to do reverse blocks on Thursday Island, in Tennant Creek, in Broken Hill. So we're flipping university teaching and it's how then we're going to go to them, because I think it's really important that we don't just offer these this degree to people who have the time, the capacity and the support. We need to be able to try and make sure that it's more equitable. So that's the grad dip. Does anyone have any questions? I've got some pretty cool alumni in this room too. Just well, the kids actually, because we did have someone on our team who it was slight advantage who had been to the Olympics before in basketball. Yeah. Yeah. That's a really great question. So with the graduate diploma, all of our units of study are for Aboriginal and Torres Strait Islander students only. But we do, in my team, we also do teach an elective unit in the Master of Public Health, which is open to our non-Indigenous brothers and sisters as well. Yeah. 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 I would say our Master of Philosophy unit would maybe be better because we're block intensive, so it's hard for people to just tap in and out. But we do teach PUBH 5120, which is Aboriginal and Torres Strait Islander Public Health, same team. My team teaches that as well. Yeah. Yeah. Anything else? Oh, cool. Thank you. Thanks, everybody.
Thanks so much, Candice. Amazing as always. Next up, we've got Anne Sheridan and Shani Roberts for Wellmore. Give them a big hand. Yep, you got it. And it might just come up. Which is this one? I'm just going to put that in. Jingla, hello everyone. My name is Shani Roberts. I'm a proud Widgeable Wyable woman, direct bloodline descendant of this country, and I'm very proud to work on the Wellmore project with my colleague Anne Sheridan. But before we begin, I'd just like to start by acknowledging the Widgeable Wyable people and pay my respects to elders past, present and emerging, and just extend that acknowledgement to everybody who is attending today in the spirit of reconciliation and working together. for greater health outcomes for our people. So it's
And as Shani said, I'm Anne Sheridan. I'm a Wiradjuri woman born and raised here in beautiful Widjabul country, where I'm also raising my two Widjabul girls. I feel like that connection to country was really important for me to stay in the area, and I'm so glad that I have, because I've found myself here at the UCRH and working on the WellMob team. In acknowledgement, also just wanted to recognise the many voices that have gone into the WellMob project in its initial stages, which was a research project. Aboriginal and Torres Strait Islander frontline health and community workers' voices really informed what WellMob is today, and that's one part of it that we're really proud of.
yeah.
So today we're going to be yarning about what WellMob is and the importance of understanding the social emotional wellbeing framework in terms of health and wellbeing work. Some of the key steps to using the WellMob website and our newly developed resource sheets for workers.
But before we begin, we just always like to explain a bit about who we are and where we're from. So WellMob is a part of MPRAC, which stands for E-Mental Health in Practice. MPRAC is a consortium made up of various partners, so Black Dog Institute, Menzies and QUT. WellMob is a bit of a collaborative project between the Australian Indigenous Health Network and MPRAC. But WellMob differs from our partners because it's a one-stop shop of a bit of a one-stop shop digital library of social and emotional wellbeing content, rather than strictly focusing on just mental health resources. And we talk a little bit more about social and emotional wellbeing by referring to the framework further on in this presentation.
So rather than us just yarn to you about what WellMob is, we've actually developed a short video that describes it really perfectly.
WellMob is a website to help our Aboriginal and Torres Strait Islander mob stay mentally strong and feel deadly. It's a digital library of online wellbeing resources made for mob from all over the country. WellMob is developed by and for our mob and brings together the holistic concept of social and emotional well-being to build connections to our stories about land, spirituality, and ancestry. Search under the main topics relating to mind, body, mob, culture, keeping safe, and healing. Or go to our training tab for health and wellbeing workers. Whether you're a health or community worker or just one of our mob, the WellMob website is your one-stop shop for digital wellbeing tools. WellMob makes it easy to search for apps, websites, podcasts, documents, social media, and videos that help our wellbeing. And it's not just about mental health. It captures our stories to connect us to country, culture, and our diverse communities. It's that easy. Search WellMob. Watch, listen, and learn about our Indigenous ways of holistic mental health and wellbeing. Go to wellmob.org.au and show your support with a like, follow, and share. These are the homes of ancestral spirits, and WellMob walk lightly with gratitude and respect.
You guys might recognise especially someone's voice in that video. Our deadly sister Taylor Laurie was the voiceover for that video, and we do sort of tend to create most of our content in-house. So just recapping and kind of updating on from that, WellMob now has over 400 Indigenous specific social and emotional wellbeing resources. I think it might have grown from 250 in about the last 2 years. And that's, something that I guess really shows the drive in our community, or the driving need for our community to have Indigenous specific resources. And then things like videos and apps, podcasts, all that consumer content. And we create them and pull them from all over the internet. So we don't actually make those ourselves, but we pull them together and post them on our website. So it does act like a library. Our target audience is for frontline workers. So clinicians and practitioners and allied health workers and Aboriginal workforce as well, to be able to use it directly with their clients, as well as for their own either further education as well as professional development. And as Shani said, it's a one-stop library of Indigenous specific social and emotional wellbeing resources, rather than being just strictly digital mental health resources.
Oh, so in such an important week where we gather and discuss working together, I think particularly for greater health outcomes for Aboriginal and Torres Strait Islander people, it's important to acknowledge the social and emotional wellbeing framework to further understand health and wellbeing from an Indigenous perspective. We know that mental health and mental illness focuses too much on problems and deficits, and doesn't properly describe all factors that make up wellbeing, and just tends to be quite individual focused. So the term social and emotional wellbeing, it recognises that the importance of connection to land, culture, family and community are important factors to our wellbeing. However, it also recognises that a person's social and emotional wellbeing is influenced by past policies and events, and very real and raw, but it's the truth. You know, things like invasion and dispossession and segregation and assimilation, stolen wages, you know, that payment in tobacco and alcohol, and the breakdown of the family structure, so stolen generation, sexual abuse, very raw, but it's the truth. And the social and emotional wellbeing model recognises that these past practices continue to have ramifications on First Nations peoples today. And that's reflected in trauma or higher psychological distress that mob may feel in comparison to our Australian counterparts, anxiety, depression, things like that. So WellMob is based on the understanding of the social and emotional wellbeing framework, and the term mental health is often linked to stigma, negative attitudes and beliefs for our broader populations, but even more so for our First Nations peoples, particularly, you know, shame job being so much more prevalent among our people. So social and emotional wellbeing is holistic and it's strength-based. That is consistent with Aboriginal ways of being and doing. Misunderstanding, misdiagnosis and mislabeling of mental health conditions for Indigenous populations happens and occurs if we don't take into consideration the social and emotional wellbeing framework. We know that the social and emotional wellbeing framework is broader and is a multi-dimensional concept, as you can see the diagram here on the screen, which describes the 4 domains and describing its interconnectedness. The determinants of the social emotional wellbeing framework, we look at the 4 determinants of the social emotional wellbeing framework. The social, such as things like employment and housing and education. Historical, which includes legacies of colonisation, disruptions, dispossession of land, family, culture, languages, and removal of children to the present day. Present day factors also, such as racism and discrimination. The political domains, which refers to the importance of human rights, of all peoples and self-determination, sovereignty, and social justice.
And the cultural domain is the perspective that finds solutions in stronger connection to culture, community, and country. And then the subheadings recognizes the interrelatedness and the value of connection to mind, body, emotions, family, kinship, community, culture, country, spirit, spirituality, and ancestors. However, looking at these subheadings without the broader context of the social, historical, political, and cultural factors can result in misleading understanding of what is actually happening for a person. So WellMob is based on this understanding of the value of social and emotional wellbeing in promoting wellbeing. And all the resources, as Ange has mentioned, that you can find on WellMob fit the social and emotional wellbeing criteria, and privileging Indigenous ways of doing, knowing, being, and valuing that connection to culture, land, family, and community. I'll now hand over to Ange, and she can talk about using WellMob in practice.
Yeah, so there's a couple of different ways that you can use the resources on the WellMob website in practice. The first way that we talk about is sharing online resources in direct client-facing roles. So that would be, in session, and that can be really useful to unpack topics that might be tricky to talk about or might have stigma attached to it, and that shame factor. And sometimes looking at a third-party resource takes the focus away from, the clinician and client, and, being able to look at a video together and then talk about the video and talk about, unpack the video together, takes the onus then off the client and the focus of them, which may sort of destigmatize and make it less shame to yarn about, and it opens up the conversation a little bit easier. And then the other way is in community to use the resources on WellMob in a health promotion way. The second way that we talk about using WellMob is to support our workforce. So we know, our workforce is more often than not time for, under-resourced, overstretched, under the pump, and they are trying their best to support our mob in health and wellbeing and have really well-meaning intentions. Sometimes there can be a bit of a cultural divide, and using an Indigenous specific social and emotional wellbeing resource can help to bridge that gap and be able to communicate about social and emotional wellbeing in a way that mob understand and feel comfortable and safe, so that does promote that feeling as an Aboriginal person of cultural safety in a client's clinician setting. Now else? For workforce, Aboriginal workforce, any of the resources on WellMob can be used for your own self-care and wellbeing practice as well, which we acknowledge is, vital in any role working in community, with the colonial loads that we might face in our workplaces, but then also, our community and family obligations that we all carry as well. So by having and maintaining that balance and being able to use online resources in that self-care practice, we have found can be really useful to use the WellMob resources for that. I've gone off book, so I didn't really follow my notes. Let's double check. Oh yeah, and I mentioned it at the beginning, but so using some of the resources on WellMob are actually for, further education and learning, as well as professional development, and can be really great for non-Indigenous workforce to be able to learn more about social emotional wellbeing, impacts of colonisation, trauma and healing, and look at some of the other best practice ideas, in a way that is probably safe and easy to consume, because it is that user consumed content. So those resources can be found on the main homepage. There's a training tab up the top, and that will drop down into about 9 different, when you click on training resources, that'll have about 9 different topics. And then under that is a whole bunch of resources that you're able to use for, professional personal development.
So we have over 400 online resources on WellMob, and we recognise that looking through those resources can be quite time consuming. So we have recently developed these resource sheets, particularly for workers, and they are shortcuts to what we think are the best resources on a range of common health and wellbeing topics. As Anne mentioned, you can find these on the home landing page. We've actually got a banner there that says shortcuts to the top resources that you can easily access. An example of a resource sheet, we have quite a few now, I think over 15. There's ones on suicidality. These sheets, resources are for a person who's experiencing suicidality, another for family and community who is supporting that person. But there's also sheets on anxiety, cultural identity, parenting, and ones particularly that could be used around Black professional development and cultural awareness. So like understanding the impacts of colonisation, trauma and trauma-informed care, understanding social emotional wellbeing, etc. And here's just an example of some of the sheets that we have created that are quite, I guess, relevant. It's great for enhancing sort of workers' understanding, like I said, around social emotional wellbeing, the impacts of colonisation, understanding healing from trauma, which is a combination of resources to build workers' understanding and of some who's directly working with these people, family or communities. The resource sheets are two-sided and provide an excellent supplement to cultural awareness, as mentioned.
And this is our newest addition to the resource sheets. It's only been uploaded to the website late last week. But it's been something that's been in development, for most of this year. We as a team, really acknowledge that non-Indigenous workforce who work with mob can have the biggest impact on their health and wellbeing, but also can be really great allies to our community. And, after what happened last year with the referendum campaign, even though that wasn't necessarily the best outcome, what was really great is that it identified a lot of new allies. And, I think there's a lot of power in that within our country, a little bit of hope that came out of, the result of what happened last year. So we scoured the internet and pulled together some of what we think are really great resources for non-Indigenous people to be able to strengthen their allyship. And, we had with colleagues here with Danny Marcel and, looked at it a bit further and, also acknowledged that there's different phases on that allyship journey and people are starting out at different points. So we've created this resource sheet for people to be able to tap into where they are at and to build their understanding, their knowledge and, strengthen their allyship.
Cool. So to recap, WellMob is a digital library for both workers and community members. WellMob hosts culturally relevant resources that are developed by Aboriginal and Torres Strait Islander people for Aboriginal and Torres Strait Islander people. As Ange mentioned, we don't create any of these resources, but we curate them. So we pull them from all across the country and place them in one spot so workers can easily access these resources that are available to them. Yeah, all resources are consistent with the social and emotional wellbeing framework, which is considered best practice when working with Aboriginal and Torres Strait Islander people. And also offers non-Indigenous workforce the opportunity to enhance their understanding and skills to work effectively with Aboriginal and Torres Strait Islander people. Yeah. Be sure to check out our resource sheets for workers, which we're happy to always showcase. And that's really it.
And you know, it's constantly evolving, the online space, and we're continually adding new resources to the website. So it's a really, great idea to stay connected to us, and the different ways that you can do that is by following us on social media. We've got quite a consistent and large presence on social media, not just because it's my role, but we really look at that space in terms of health promotion and information sharing, and it's a really great way to be able to, I guess, disseminate the work that we're doing and be able to share that with all of the community. So yeah, definitely follow us on socials if you're interested. Subscribe to our e-newsletter, which is every second month, and we have a list of our newest uploaded resources in that.
Thanks. Any questions?
There are some resources on there that do have CBD points. They're usually like accredited CBD points. You need to have like the after number to do that. But yes. Anyone else? That's great. We covered everything, guys.
Thanks, Shani and Ange. Now we'll move into the panel discussion, and I'd like to invite down Professor Vicky Flood, Emma Walk, Jack DeLacy, and Dave Edwards. If you just want to come down and sit along the front chairs, that'd be great.
Yeah, it's been hot.
Thank you. Can I still stand here and ask the questions? Like that. If something comes on, is that okay? Okay, so thanks so much to our panel today. I really appreciate you guys saying yes to this. Our discussion today will explore the topics of truth-telling, truth listening, and how you are able to actively play a part in reconciliation. So I've got a couple of questions to ask the panel, and we'd love to hear what you guys have to say. So the first question is, what would it take for us to all truly stand together now more than ever? Anyone?
Now it's working, I think. Yeah. So thank you for advance notice of the questions. That helped. So I've been reflecting on this question the last week or two, And I was thinking about an experience that I did in 2000 and the bridge walk. So that was a time when people came together and stood together to walk across the Harbour Bridge. And so I did that in my mid-30s with my husband and my then 8-year-old and 5-year-old. And it was such an amazing event to be part of. And I was thinking about what had led to that point where we had 250,000 people walking across that bridge that day on the 26th of May in 2000. What brought our country together at that point? And it had come out of, I think it was coming out of some politics around people were a bit angry with the then government, and they were concerned about why weren't we doing something about saying sorry and facing up to the terrible history that we'd created. And people were wanting to make a stand and come together and talk about it together and face that history and tell those stories. And it was such a wonderful moment in time. Was anyone else there? Yeah, you were. Yeah, you were there. And it was a great day, wasn't it? It was, but then now we've had what happened last year. And that came out of a sense of frustration. And a recognition that we weren't doing enough. And so I hope it brings some hope that we can move forward from what happened last year. And yeah, and to tell those stories and to recognise the part we played in those stories. Yeah, there's a sadness for me that I have come from a descendant from first generation. So that really came home for me too, and another on-country experience. And I only hope that my only little thing that I take from that is also that at least it was a woman first leader, and so a woman convict. But I feel sad that I was that I'm descended from that generation that invaded your lands. Yeah. So I think that story needs to be told because that's part of the truth telling that needs to happen. Yeah.
I think, Tracy, you mentioned in your introduction, truth listening. I think that's really important. I think one of the things that I've learnt working with Aboriginal people, Aboriginal communities is deep listening. So always sort of, you've probably heard it a million times, but don't just listen with your ears, listen with your heart, listen with your soul, like deeply listen to community. And I think that it's really important that more people do that, particularly non-Aboriginal people in this country. And it's not just about acknowledging and recognizing truths. It's actually very empowering, it has been for me. I think it's made me a better researcher, a better health practitioner, a better person, and my understanding of the deep history and culture of where I live has really enriched me deeply. I had the privilege earlier this year walking around the campus of Sydney Uni, Camperdown campus, and also walking around Glebe with a local elder, Uncle Jimmy. And he was able to point out every tree in the area. He knew exactly what tree it was. Was able to tell me everything about it. We were collecting leaves. We collected those leaves, and then we got students to participate in a smoking ceremony where they were able to man the coolamans. And some of the feedback from the students was, this is a first experience that they had sort of really engaging with Aboriginal and Torres Strait Islander culture and how impactful it was for them. So, and they were listening to Uncle Jimmy, and they did, I think, get a lot out of it. So I think that deep listening is, I think, what we should be doing more of.
I think they're two very good angles to discuss this theme of now more than ever. One about the, I guess, truth-telling and the sorrows of this country and the sadness that lies within the land and in our people. And it's really important as part of healing to acknowledge that sadness. And it's a long play, you know, it's not something that gets fixed overnight. I think it's the things we can do every day with our First Nations colleagues or in our communities that make a difference, not just what happens on Reconciliation Week or NAIDOC Week. I think it's, you know, that showing up every day and thinking about First Nations perspectives and privileging First Nations voices in discussions. And I really like, Jack, your contribution around the strengths and the benefits of Aboriginal culture. Like, you know, a lot of people just think about, you know, saying sorry or the closing the gap and some of those negative discourses that are around, but hearing about people's experience of learning and sharing in Aboriginal culture, there's so much benefit out there that non-Indigenous Australians can carry forward with them. And whether it's a smoking ceremony, whether it's hearing a yarn about a particular tree or animal and how that might have come to being in our Dreamtime stories. There's so much information that's out there that's accessible too, and WellMob, as you heard, and Shani is a great place to look for some of those narratives. But yeah, there's so many more benefits to this country to enrich non-Indigenous Australians' lives by looking into and experiencing Aboriginal culture.
Is that in there? Do you want me to say? Just might check if people have got their mute on. Well, I think everybody's kind of answered it, but I suppose I feel, I think there's so much sadness from last year. And I know we've talked about it a lot, but I think it's been so difficult to, I don't know,
Articulate.
Yeah, articulate it. And, but also just even to, you know, mull it over and deal with it inside. And it's not just like I think for quite a lot of people, there's that response it sort of just sits there. There's nothing, you know, it sort of lies dormant within us. And I feel, I certainly know a lot of people that I've spoken to are so extraordinarily angry, like so angry. But what do you do with that? And so a small part of me wants to be quite political about it. And I think that there needs to be more pressure. There needs to be more opportunities for like doing things like this is fantastic because we're being honest and we're talking about how we feel. And I think that needs to happen more often, particularly because we haven't had a voice for such a long time. And I think that everybody has a right to everybody needs to understand how Aboriginal people feel about this, whether, you know, obviously there are going to be people who were against the voice.
Thanks so much, guys. So the second question that I had for you is, what would it take for everyday Australians to become more informed, and what would honourable partnerships look like, do you think?
So I brought some show and tell because that's a bit of fun to have. So I think it's really helpful to read widely. So I grew up went to school in the 70s and early 80s. So a lot of people at my age would also be in that experience where the history that we had around Aboriginal people was either non-existent, was silent, or it was incorrect. And so we've had to learn as adults and read widely and listen to stories, listen deeply, and learn from people like yourselves and the systems like that. But not everyone's had that opportunity or made those opportunities. And so we have to think about how we can communicate in different ways. So some of the readings that I've done the last couple of years, Stan Grant, talking to my country. Such a powerful writer. Lot to say, a lot of hurt there. But probably many of you have read this one, have you? Yeah. So my encouragement, I'm in the middle of reading this at the moment, guys, in Glassy. I've only not long started. And so this is going to be the next book club discussion, isn't it? So really looking forward to that discussion. Hopefully I'll be around when we have it. So I'm going to leave shortly for a little bit, but that's the rest of that book's going to be read on the plane. It's at Glassy. Sorry. Melissa Lipnichenko. It's well worth it. And so this team run a terrific book club once every 2 or 3 months with students and staff, and I encourage you to participate. It's a really good thing to be involved with. This is a fiction work by Anita Heiss. It's about, it's a fictional work set in early 1800s in Australia. Just a big heads up, there's a big flood in it. It's set in Murrumbidgee, but it tells some really powerful stories, and that's what. And here, this one is Our Way Stories, local Bundjalung people describing local stories. This was given to me by my mother among her collection, and it's got great stories from aunties and uncles from Bundjalung Nation people. So I encourage you to be thinking about that. And of course, on the weekend, Dave gave me this ahead of time to think about, to help me with my thinking, being a good ally, resource sheet from WellMob. So check out the WellMob site. I encourage you.
I was just reflecting on my own experience, I suppose, and I think I was really fortunate as a young boy that in my school we had elders come into the school and teach us about Dreamtime stories, would teach us about local bush tucker, and it gave me a connection to country as a young person, and it also instilled in me that this is Aboriginal land, this is Aboriginal culture that's embedded in the place that I grew up. I think that's really, really important, but most kids in this country probably won't get that even now. And so I think, that is really, really important. It's also when I reflect on my experience in school, I remember always being told, oh, Jack's a bright boy, but he doesn't pay attention. But the time I remember really paying attention was getting out of the classroom and, listening to the elders that would come down, because we were doing stuff that was engaging. We were, really learning in a much better way than sitting there, in the classroom, watching the teacher up the front write something on the board or whatever. But yeah, I don't know. It just made me reflect on maybe why I am really excited to engage with Aboriginal communities, Aboriginal people, Aboriginal culture. And I'm sure that it's because it started early.
Thanks, Jeff.
Yeah, thanks, Jack. That's so important. I think education, educating our next generation and maybe do a better job when the voice referendum comes around next time would be a really good start. And I think, we've all got a responsibility to self-educate ourselves around the First Nations people of this country and our history and our ongoing contemporary culture. We express that through dance and sport, through literature. And also, as I said, I really encourage people to get involved with community events. I know Lismore NAIDOC event's going to be here this year, which is great for school kids. And it's fantastic to see those schools that bring their non-Indigenous kids along to NAIDOC week. And it's not many. A lot of people think, NAIDOC week is just for Aboriginal people to celebrate Aboriginal culture, but in the spirit of reconciliation, it's a great event to attend, and it's good. I love seeing those non-Indigenous jargons there and mixing with the black kids and enjoying the day and you know the amount of culture and education that happens in the schools in Bundjalung country is really, you know, a testament to some of the elders and knowledge holders of this area, and whether it's teaching language or traditional dance. You know, we live in a pretty special community here and culture lives on.
So,
I think the other thing is like, I mean, things like these, again, I say is really good, but you guys turn up, you show up, that's important. And I think showing up is really important for everybody at all times. I think you're right about education. But I just want to, this is one of the things that I find over the years talking to people, and particularly students around Aboriginal and Torres Strait Islander people and health and culture, is that this country doesn't look at its First Nations people or its Aboriginal and Torres Strait Islander people in the same way other countries do. So if we go to France, or if we go to I don't know, if we go to Vanuatu, we're going to look up what's going on with the traditional mob there and what they're doing and what their culture is like, and that's part of why we go to those countries, or any country, is to experience another culture. That's not how we consider our own country. We don't even think about it. In fact, I think that's probably been one of the major. It's a major downfall of this country, but also something that we need to change. That actually, it's when you get to New Zealand and they have all this amazing, you know, artwork around of the traditional mob there, and you can see, you know, you're in a different country, you know, you can experience a different culture. We don't do that here. Only some places, and it's usually the NT. They got it going on. We don't, and it's disappointing. And so I think for me, that we have to start changing the way we think about Australia as a country. Everybody, how we talk about it. Because it's not about ownership. It's not, I mean, it is about ownership, but it's not like, well, we own this and therefore nobody else owns it. It's just that we were here first and this is where we are now. But we don't talk about it like that. And I think we have to change it. Sorry, I'm going
to. Thanks, Em. And just our final question today. What do you feel your role in reconciliation is? Just an easy question.
I think for me, probably keep doing what I'm doing, which comes back to the first answer, which is deep listening. Every time I go and have a yarn with community, I learn a lot. I think, as David was saying before, he said it was really important to be talking about strengths. There's two things that I like to always talk about: is how important ears are in hearing, and the strength of Aboriginal people, Aboriginal culture. It's not hard to miss when you actually step foot in Aboriginal communities. And so I think I'll just keep talking about that and encouraging people that haven't done that to do that, or encouraging my research fellows that you know, haven't engaged in Aboriginal and Torres Strait Islander research. I'll, you know, keep saying, if you want to be a better researcher,
I think also, from my perspective, my job in reconciliation is to kind of just continue having really open conversations with people. I don't judge people. I think it's really important to not make people feel responsible because they're just not. It's just that people today, they're just not responsible. What they're responsible for is things that they do today, which, is, for example, the referendum is probably a really good example of that. No, but like have conversations. People need to feel safe to say their truth and their thinking, and I think we try and do that a lot with the students. Make that safe. I mean, make our space safe. We say whatever you like. We're not going to get offended. We might not agree with you, but that's okay. We don't have to agree. We're all different. And I think people are pretty magic. I think if you can have an open, honest conversation and help people understand something different, then that's great.
Yeah, thanks, Sam. I think it's important for me, as part of reconciliation, to share parts of my culture that I can share, because there's a lot that I can't. And I'm privileged to, over the last sort of couple of decades, to be involved with a group of men that renewing our cultural links and practices. And it's something that, I really love sharing the little bits that I learn. But for me, my role is really about trying to reconnect with my culture and also support other young men to follow that journey. And until we can reconnect and renew our cultural links, we're probably not in a place to share. And I don't say that sort of selfishly, but there's been a lot of loss of knowledge, a loss of traditional practices that a lot of us are still just learning, and it's a lifelong journey. And I think as we get to know it and to be given the privilege that we are allowed to share that, we'll do our bit.
Yeah, I think I'm the director of the centre, and I look for ways of removing barriers that might be put up or around First Nations people to be engaged, to be part of the centre. I mean, you guys are doing and doing a great job and had that great space, but yeah, and that's been built up over a period of time, and so value all that's been done here in this space. But I'm also looking to think about acknowledging the leadership you provide, Em and Dave and Veronica, and just ensuring that that's available for people to see, and stepping back and allowing you to do that leadership that you do all do so well, and making space for that. Yeah. So I think that's a big part of the role that I have as being, as the head of the school, and ensuring that we can continue to value and build workforce for the future, so that we have that dream and we see the future that's coming from the younger generations too. So it is, it's exciting to see where it could go. I think there's just so much here that's happening in this space, and you guys contribute so much. So thank you.
Thanks, everyone. And just to finish off today, I'd just like to revisit something that I spoke about this morning. What does your change start with this Reconciliation Week? For the non-Indigenous people in the room, it's great that you put a poster up on the wall. It's great that you put something at the bottom of your email signature. We all appreciate that, but what will you do? Thanks for everyone today for coming and zooming in, especially you guys zooming in. I know that would have been a tough, long few hours, but hopefully you got as much joy out of it as we did. So thanks. Thanks.
Can I actually just also say thank you for organising